Good morning, everyone. My name is Theeraphat Kotimanusvanij from King Chulalongkorn Memorial Hospital. For this period, this topic named updated toe elbow. And first of all, I have to confess that when I was assigned to do this topic, it was my first time hearing this disease. So first thing that I did was asking ChatGPT. We have to accept that AI technology improves so fast. So let's take a look. The toe elbow is the condition that commonly affects the athlete, involving inflammation and pain on the inner side of the elbow. So what toe elbow theory is, it is the umbrella term used for number of painful overuse injury in the elbow, most commonly seen in baseball pitcher and the other athlete who perform repeated throwing motion. The elbow is intermus joint which have primary stabilizer that were ulnohumeral joints, MECL, LUCL, and secondary stabilizer that were common extensor and flexor pronator mass. Key anatomy that less strain for organ force is the UCL that has three bundles, anterior, posterior, and oblique. For the anterior bundle, is the primary stability against workout stress from full extension to 90 degrees of flexion. And the posterior bundle provides functional important less strain between 60 degrees of flexion to full flexion. And in 2011, Dr. Lutun DiFaro published finding of the UCL footprint that extend from the O1, distally from subtubercle to ulnar insertion of the brachialis muscle tendon. This finding affect the new reconstruction technique. And in 2019, Dr. Hoshika published on Clinical Anatomy Journal, they found new tendinous septum from cadaveric study of 24 elbow. The tendinous septum composed first one is between PT and TDS muscle, and the second one is between DS and FTU muscle. Medial the brachialis muscle also into septum with FDS and FCS and neurosis from the tendinous complex. This finding helped to decrease soft tissue disruption during the procedure, including tendinous complex and joint capsule, and facilitated a steady recovery after UCL surgery. About the biomechanics of the throwing. The throwing motion is kinetic chain force from lower extremity to upper extremity. Two phases that affects the throw elbow is the lead rate cocking that involves increasing elbow flexion between 90 degrees to 120 degrees and forearm pronation to 90 degrees while maximize shoulder abduction and external rotation. And the next is the acceleration phase. The elbow is rapidly extended as the humerus adduct and internal rotate during coordinated forward movement of the upper extremity and trunk. This stage terminates with ball release over 40 to 50 milliseconds during elbow accelerated as much as 600,000 per sec. In acceleration phase can cause 64 Newton per meter of the workout torque at elbow, which tensile state of the UCL is only 34 Newton per meter, so UCL is weakened over time. During overhead throwing, a large workout force on elbow created by humeral torque is altered by rapid elbow extension, creating significant tensile stress along the medial compartment, shearing state in the posterior compartment and compressive state in the lateral compartment. The repetitive and near tensile stress cause microtrauma and attenuation of the anterior UCL, which lead to the progressive workout instability, stretching other medial structures such as flexor pronator mass and ulnar nerve. Shearing state and impingement in the posterior compartment cause the alternative osteophyte, loose bodies, and articular damage of postomedial trochlea. From the previous slide, you can guess the differential acts of the throw elbow. And doesn't anyone know this man? His name is Shohei Ohtani, Japanese professional baseball player who is rising star of the Los Angeles Angels in Major League Baseball or MLB. He is known for the exceptional ability both as a pitcher and hitter. He signed for the 10 years contract about $700 million, that the largest ever in the pro sport. In August last year, he had clinical of the medial elbow pain that made him living during the game and the whole season. After investigation, his diagnosis is a light UCL torn. Let's focus on the UCL injury. That first described in the 1946 in Toronto, and first reconstruction was operated by Dr. Job to a patient named Tommy John in 1974. And for the history and symptom, first of all, you have to know knowing the patient, and you have to know the injury mechanism, previous injury, sport and level of the competition, history of the overuse, how this injury affect the performance, and throwing arm dominance, location and time of the pain, throwing velocity, previous treatment, and the last one is the previous medial elbow surgery. And there are systematic review of biomechanics and motion analysis, study of baseball pitching and throwing. 5 factors that increase elbow stress. The first one is the pitching mechanic. Second is the arm slot, especially sidearm position. The next one is the pitch type, especially fastball. And the next is the pitch count and overuse. For the last one is the shoulder influence. The physical examination, you have to inspection, palpation, ulnar nerve examination, stability assessment, milking, manual test, Walker's attention overload test. For the imaging modality, the gold standard for this disease is the MRA or MRI with arthrogram that can improve the sensitivity to 92%. And before we step to the treatment, we have to know the thrower elbows can be prevented. Major League Baseball suggests you pitcher to follow this protocol to prevent elbow injury. For example, if you are 20 years old, maximum pitch per day is 120 times. But if you have 0 day to rest, after pitching, you can pitch only 1 to 30 per day. And this is not a recommendation for pitcher. Main concept is to know the limit and less enough for healing. Dr. Salemsky made this algorithm to guide treatment, published in Extremity and Joint Condition in 2019. For the conclude, if you have if you have sprain or low grade, you can go with the non-operative management. And if you have high grade, first of all, that you have to ask the patient: is this last year for your career? If yes, you can go with the non-operative management. And if it's not, you have to go with the surgery, and surgery for all complete tear. Next, how about the Shohei? How about the treatment for Shohei? The conclusion of his treatment was UCL repair to reinforce healthy ligament in place. He was operated in September last year and planned to rehabilitation for the whole this year and start pitching again next year. About the non-operative management, during the UCL tear, non-operative management focused on the shoulder, hip, and elbow range of motion, scapular mechanic, pitching mechanic, flexor pronator strengthening, core strengthening, and avoidance of the UCL tear, and other things like protocol. And during the immobilized the elbow for 6 to 12 weeks, we have to advise patient to do the scapular-based exercise and core and lower quarter strengthening exercise. Then after pain-free range of motion, start strengthening medial dynamic stabilizer and return to play after pain-free functional pattern with resistance and negative Walker stress test. For the outcome of the conservative treatment for a partial tear UCL, they are quite good return to play rate in grade 1, 2A, and 2B. And nowadays, PRP has many laws about the soft tissue treatment. What is also good outcome in UCL injury? I have the answer. There are comparative match one-to-one cohort analysis between PRP and no PRP group. For the PRP group has longer delay, return to play, and return to throwing. And there are systematic review and meta-analysis in 15 studies. The result is no significant difference in return to sport rate between PRP and no PRP group. About the operative treatment, in 2023, the modified consensus technique was conduct among 26 elbow surgery and 3 physical therapy. They can conclude the relative for the operative management. For the first one is the failure of non-operative treatment. The second one is the inability to throwing despite a trial of non-operative treatment. The next is acute high grade or complete tear. The next one is the acute of chronic tear with previous history of clinical significant UCL injury. For the last one is a complete or high grade tear in overhead athlete. For today's choice for the operative management is repair and reconstruction. This is a population-based study of the private insurance about incident of UCL tear and UCL repair and reconstruction. You will see the UCL reconstruction is over the repair from time over time because of this gold standard for nowadays. MRI case-based study by 26 orthopedic suggests operative more than non-operative in patients with proximal, partial, and full thickness tear, and distal and partial and full thickness tear. And they do the algorithm to guide choice of surgery. If you have UCL injury or suspect, you have to do MRI or MRA. If the patient has complete tear, you can choose the reconstruction in case of mid-substance tear or poor soft tissue. And you can choose the UCL repair in proximal or distal avulsion with good soft tissue. And if the patient has incomplete tear, you have to do the straight ultrasound. If the result of ultrasound was negative, you can go with the non-operative management. And if positive, you can go with the surgical management. About the repair and reconstruction, there are systematic review published in 2023 about the biomechanics. The suture augment repair demonstrate return to previous level of the previous level from the 92 to 96 at 3.8 to 7.4 months, and the UCL repair provide less gapping and they provide equivalent torsional stiffness and failure by biomechanics study. About the reconstruction has start in 1986 by Dr. Job and improved year by year. First of all, Dr. Job started with figure of S construct and they improved with the dockling technique. That was triangular construct, and the lately one is a linear construct. That today, other technique that I want to present is anatomical technique. From updated footprint of UCL in 2011, this anatomical technique, UCL reconstruction, was proposed in 2019. This technique replicates native UCL anatomy that triangulate shape insertion footprint at the ulnar side. For the humeral side, we use docking technique and fix the ulnar side with the ankle suture, each limb and loop suture, and fix to the ulnar with intercortical button. This technique provides ultimate load to failure greater than docking and similar to the native UCL. For the outcome of the reconstruction, we evaluate outcome with the return to support rate. And about the job technique, we have the outcome about 63 return to support rate. Modified job is 82, docking technique is 92 to 96, and DTJ is 86, and repair with internal bed is 92. And we didn't have the information of the anatomical technique. The next is how about the nerve? There are studies compare between ulnar nerve neuropathy and non-ulnar nerve neuropathy after UCL reconstruction. The UCL reconstruction with ulnar nerve symptom has significant or lower or return to pitch at the same level of play. And the treatment for the ulnar nerve, we suggest to do conservative in the patient that have clinical with ulnar nerve neuropathy alone. But if you have clinical with UCL tear that have to go surgery, we suggest you to do the ulnar nerve anterior transposition with subcutaneous technique that have excellent outcome. About 95% post-operative asymptomatic and return to spot at 12 weeks and return to previous play at 88%. And we have dissolved the mesh of the cohort study between ulnar nerve reconstruction and with ulnar nerve transposition and without ulnar nerve transposition. There are good and similar outcome between two groups, despite significant difference in preoperative ulnar nerve symptom, but not different in postoperative ulnar nerve symptom. And the outcome of the ulnar nerve transposition is quite good, with return to spot rate about 72.7% at 11 months. For the take-home message, it's important to know the history of the patient about training, level of the competition, and expectation. For the physical examination, we have to do at suspect structure from history, and the Vargas status is the key. MRI arthrography is gold standard for the investigation, and before we do the treatment, we have to know the expectation of the patient. UCL reconstruction means they gold standard for UCL injury, but UCL repair with augmentation was approved that was equivalent biomechanic. And the last one is don't forget the ulnar nerve during the operation. Thank you for your attention.
One question about the non-operative treatment in such a case. How about the steroid injection? What is the effect treatment and when they are going to use or something like that?
About the steroid treatment, right?
Yes.
From the review, steroid will not help to promote healing of the UCL, and it will damage if we use repetitive injection.
Because many of these patients will be treated with that form of treatment, and together with some rehabilitations. And for how long will you consider that rehabilitation is failed before you're going to do the surgeries? How long? Or what is the side that you will consider that?
If they suggest before to do the operative management, right? They suggest from the review, they suggest to do every case that MRI show the complete tear. But if we have the partial tear, we can go with the conservative management until 6 months. If they still have the clinical of the medial elbow pain or clinical of the UCL injury, we can shift to the reconstruction technique.
So for the conservative treatment, it's just only the rehabilitation, right? Because
yes.
The PRP injection is not provide good results. Don't have any other forms of medications.
Yes, the other form that can use it NSAID, and you can follow the LICE protocol.
So you mentioned about the UCL repair, right?
Yes.
And one study comparing repair and reconstruction is comparable.
Yes.
So what is your indication for repair and reconstruction?
Indication for repair for my follow from the review. Suggest to repair in the partial tear. The partial tear that was athlete with the they have to follow the career path.
Partial tear.
Yes. It can help you to improve your return to sport rate.
Not any numbers of laxities or ultrasound stress test, something that can give us more idea.
Yes.
You say partial tear is nothing.
If your partial tear, you can evaluate with the stress test from the ultrasound. If it was positive, we suggest you to do repair. But if it is negative, we may suggest you to do the non-operative management.
What is the cut point for positive and negative?
The cut point is 3 millimeter.
3 millimeters?
Yep.
Repair, right?
Yep.
Any augmentation with tape or
with tape, yes.
Repair with tape?
Yep. It was proof that it was quite good biomechanics study compared with the native. Yeah.
Thank you.
For the conservative treatment, how much extension you allow the patient in the elbow breast? You use the elbow breast, right, for the conservative treatment?
Yes.
How much extension you allow the patient for in the breast?
In the breast side. At first, we suggest the patient to in the breast with the flexion of the 90-degree of flexion about 6 weeks. At first to raise the soft tissue, and we promote to do the range of motion exercise of the the shoulder and the wrist increase.
You know, the elbow breast is a dynamic breast, not the rigid breast for the treatment. So my question is that if you have the dynamic breast for the conservative treatment of the UCL, how much extension allow? Full extension, 30, 60 extension?
If the patient start to have the pain-free, we can adjust bed to the 60 to 120 degrees.
Okay, may I ask a question? I would like to know that how the shoulder problem affect to the elbow in the lower elbow, right? You said that the girth and six scapula. I would like to know the mechanic.
From the affect the elbow, right?
Yeah, because you said that if the patient had some shoulder problem,
Yes.
it may have a lead to be have any problem in the throwing athlete.
Yes,
At elbow.
it start with it. It was a different problem because in the same phase of the throwing, they can affect both both elbow and shoulder. So I think from my review, I think it because it was kinematic change. So if you have abduction, less shoulder, or you have do the fault mechanic of the throwing, in one part they can affect the other part.